that being overweight or obese is associated with an increased risk of developing several common cancer is well known. It's also known that breast cancer survivors are at increased risk of developing second primary cancers. So what was not known was that the effect of excess body weight in increasing these risk of developing a second primary cancer in breast cancer survivors. So in this very nice study published in JNCI, one of the top cancer journals in the world, they followed for 88 months 6,480 women who already had breast cancer, been successfully treated for breast cancer for, again, 88 months. And they found that for every 5 kilogram for square meter of BMI increase, there was a 7% higher risk of developing any second cancer. There was a 13% increase of developing obesity-related cancers. And again, for every 5 kilogram, every 5 units of BMI increase, there was an 11% higher risk of developing second breast cancers and a 15% higher risk of developing a second estrogen receptor positive breast cancer. So very important data that underline the importance of excessive body weight in the development of not only primary but also secondary cancers in cancer survivors. So let me explain the rationale of these findings from a epidemiological point of view. So point number one, you have to understand that having a small tumor in the breast or prostate or any other organ, probably with the exception of the brain, is not an issue. If you have a tiny in situ cancer that doesn't grow, is dormant, doesn't kill you. And we know that this is very common. So this is a review article called Cancer Without Disease, published in Nature, discussing the fact that if you take people who had an autopsy for other reasons, who died for other reasons, or screening studies, these suggest that every individual has a microscopic small tumor, in situ tumor, in their body by the time they reach the 6th or 7th decade of life. But in most of these individuals, these lesions, they remain small and they never progress to clinical disease. For example, it has been estimated that almost 40% of women aged 40 to 50 who did not have cancer-related disease in their lifetime were found at autopsy with in situ breast cancers. But in this age range, 40 to 50, only 1% of the women, they are diagnosed with a clinical breast cancer. So 39%, they have histological cancer at autopsy, but only 1%. And if we look at ductal carcinoma in situ of the breast, we know that over 40%, 45% of women with cancer, with breast cancer of ductal carcinoma in situ, had 2 or more lesions. It's not only one, they have 2 or more lesions. And over 40% had bilateral lesions, meaning that not only, even if they have been surgically, the tumor has been surgically removed, for example, in the left breast, 40% of the women or more, they have most likely another small, 1 or more small lesions in the right breast. And The problem is that this is common for many other cancers. Let's take thyroid cancer. Virtually all individuals who had an autopsy for, again, in a car accident, whatever, age 50 to 7, have an in situ carcinoma of the thyroid gland. In contrast, only 0.1% of the individual in this age range will develop a clinical significant thyroid cancer, so a thyroid cancer with a size of more than 2 centimeters. If we look at the prostate cancer, is the most common cancer in men. We know that the prevalence of clinical cancer, so cancer that has been diagnosed in men age 60 to 70, is only about 1%. But in the same age range, more than 40% of the men with a normal rectal examination, they have an in situ histological prostate cancer. And if we look at the age over 90 years, if we take men who are older than 90 years old, 80%, basically almost everybody, if you do an autopsy and if you do a careful pathological examination of their prostate, you're going to find an histological evidence of a small prostate cancer. Okay? So this is a very important concept because, let me just make an example. This study published in 1983 by Dom is comparing basically histological prostate cancer and clinical prostate cancer. And let me remind you that it's not histological prostate cancer or any other common cancer that is going to kill you, but it's going to be the metastatic cancer. So when the cancer is growing, proliferating, and then becoming more aggressive and eventually becoming metastatic. Or the metastasis in the great majority of cases is killing people, not the local cancer. So again, in this study, they compare the prevalence of histological small prostate cancer within the prostate in Japanese and US men, and the prevalence per 100,000 men, as you can see, of histological prostate cancer does increase exponentially with age, but it's exactly the same in Japanese and Americans. However, if we look at the prevalence of clinical prostate cancer, the cancer that kills people, the prevalence per 100,000 men is very, very, very low in Japanese, or at least was very low when they had a healthy lifestyle. You see, it's a very tiny increase with age above 75 years old. But instead of in the Americans is exponentially increasing starting from 55 years of age. So there is a huge increase in clinical prostate cancer, suggesting that there are a number of factors, hormonal, metabolic, inflammatory factors, lifestyle factors, that are promoting the growth of the tumor. So the small lesions is growing faster, becoming more aggressive because it's accumulating more nasty mutations that make this tumor grow and metastasize. What are those factors? Those factors we are finding that are basically linked with your lifestyle. So if you are overweight, if you are gaining weight because you have an excessive caloric intake, you had a sedentary lifestyle, you have an unhealthy diet promoting, again, weight gain and also many other complications, what happens is that you are starting to accumulate excessive fat, especially in your abdomen, abdominal obesity, visceral adiposity. And we know that, these hypertrophic adipocytes produce a bunch of adipokines and pro-inflammatory cytokines that are causing insulin resistance, systemic insulin resistance. This insulin resistance is causing compensatory hyperinsulinemia, but at the same time is reducing SHBGs, their hormone binding globulin, and then IGF-BP1 and BP2, therefore increasing the bioavailability of IGF-1, testosterone, estrogens. There are powerful anabolic factors and growth hormones. So these three, hyperinsulinemia, IGF-1, testosterone, estrogen, and even leptin have are promoting cell proliferation. Okay, and whenever you have, whenever these small tumors, these in situ small tumors, they are bathed in this environment, this microenvironment rich of these growth factors and anabolic hormones, the cells are proliferating more. We exactly know what happens. There is an increase in cell proliferation, and because there is an increase in cell proliferation, there is an increase in random mutation. So the cancer cells, they become more and more aggressive because they accumulate randomly more nasty mutations. There is also a reduction in apoptosis. Therefore, the cells who are mutated, they cannot die because of these growth factors inhibiting apoptosis. These growth factors through the AKT, insulin IGF-1, AKT, FOXO-mTOR pathway is also inhibiting DNA repair activity, so the capacity of cells to repair DNA damage, and we know these factors are promoting with inflammation genomic instability. Now, apart from these SHBG insulin resistance mediated effects in increasing estrogens, we know that people who are have excess body fat, they have an increased production of estrogens through a direct role of adipose tissue increasing the activity of an enzyme called aromatases. And so there is a direct effect on estrogen apart from this mechanism. And by the way, sleep deprivation, fragmentation, and mental stress, they increase insulin resistance through a catecholamine cortisol pathway. But then, there are other effects on cancer due to unhealthy diet and exercise that is driven by inflammation, increased oxidative stress, there is increasing again mutations, an increase in cell senescence, and the secretory cell senescence, secretory acidic phenotype is producing a bunch of growth factors and pro-inflammatory cytokines, and in an unhealthy diet by changing the composition and function of the gut microbiota is also influencing the risk of developing cancer directly of the colon, but also indirectly of other tumors through an immune mechanism, an immunity mechanism, because we have discovered in the last few years that the immune system plays a major role in recognizing and killing cancer cells. But there are beautiful publications showing that obese individuals, people with metabolic syndrome and other metabolic abnormalities have dysfunction of these immune cells, of these T cells and NK cells, and therefore the capacity of the immune system, the surveillance capacity of the immune system is reduced. Of course, all these metabolic, hormonal, inflammatory, immune factors are interacting with our environment, where virus, bacteria, carcinogenic substances, smoking, pollution, radiation are promoting the increase in random mutations that in some way can be repaired by some of these mechanisms. But then, as we said, the problem is really the cell proliferation that is making a small in situ cancer become aggressive and metastatic. Let me finish with another important concept, because as clinicians, we are typically dividing people in normal weight, overweight, and obese based on BMI cutoffs. So if you have a BMI between 18.5 and 25, you are normal. If you have a BMI between 25 and 30, you are overweight. And if you have a BMI higher than 30, you are obese. So most doctors, they start to counsel their patients to do something about their body weight when they start to become obese. Typically they use a cutoff of 30. Then say, okay, maybe you should see a dietitian. You should do something about your body weight. But I think this is wrong, and let me tell you why it's wrong. Because let's say you are a freshman, a teenager, 20 years old, and you are lean because you are doing your sport, your activities, and your height is 1.7 meters, and your weight is 55 kilos, so your BMI is 19. Let's make an example. Can be also this one, but 19. If this girl she gains 6 kilos in 6 years, let's say 1 kilo per year, that is typical of in Western societies, her BMI goes from 19 to 21.1. So still very, very lean. If this girl from 61 kilos goes to 67, so she gains another 6 kilos, her BMI goes from 21.1 to 23.2. That is still considered very normal in our society. If she gains 22 kilos, her BMI goes to 26.6. That is mildly overweight, just the beginning of the overweight cutoff. And if she gained 32 kilos, her BMI is going to 30, so basically borderline obese. But she gained 32 kilos. Let's say, even if you start from 21.1 of BMI, 61 of a girl of 20 years old, and you gain basically 5 kilos, your BMI is still super healthy, considered very healthy. And again, here, 15, 16 kilos, 26.6. But what we know is that for each 5 kilograms weight gain, so if you start for your optimal body weight when you were 20, if you gain more than 5 kilos incrementally, your risk of diabetes, type 2 diabetes, hypertension, cardiovascular disease, and many of the obesity-related cancer is much, much higher. And that's in line with the paper we discussed at the beginning of this lecture on second cancer in women who had already a diagnosis of breast cancer. This is the mechanistic explanation of why you should take control of your health. And even if you were unlucky and you had a cancer and you have been treated with cancer, and let me make this point clear. If you have cancer, there is no scientific data showing that diet, exercise, or any other lifestyle intervention or phytochemicals can treat your cancer. If you have cancer, you have to go and see the best oncologist you can, surgeon, and you have to do whatever you have to do by surgically removing the cancer, or with and without chemo or radiotherapy. So go to the best oncological team and take care of your cancer with the best medicine. However, my point is that once you have been treated successfully for this cancer, what are you going to do? So are you going to still doing what you were doing before? Are you still being overweight, having high insulin, high bioavailable IGF-1, testosterone, estrogen, inflammatory cytokines, and all these factors that we know are promoting the growth of tumors and of secondary tumors? Because as I told you, the great majority of people, when they are older than 50, they have some tumors, small tumors, latent in situ tumors in their body. What you have to do is to keep these metabolic hormonal risk factors very low so that the tumor stays there, remains small, and doesn't kill you. And therefore, even if you already had cancer, you should act, you should take control of your health and minimize the risk of the other small tumors in your body to grow. So that's the message that I think is a very important message that you should be aware of. And this is based on very well performed studies that, if you're interested in understanding a bit more of what we know in 2021, I just published a couple of review articles in the top medical journal. This is the number 1 and 2 most cited with a higher impact factor journal in the world is a CA Cancer Journal for Clinicians, where I discussed with Lindsay Patterson, Cynthia May, and Catherine Clifton the importance of calorie restriction and diet quality and fasting in the primary and secondary prevention of many common cancers. And then there is a more technical molecular review that we just published this week in Nature Reviews Molecular Cell Biology with Dudley Laming and Cara Green on the effects of different type of dietary manipulation, dietary restriction, protein, methionine, and other amino acid restriction, fasting, intermittent fasting, and prolonged fasting in controlling the metabolic molecular pathways that are promoting or increasing aging or longevity and cancer, because cancer and aging, they are two sides of the same coin. Thank you for listening, as always.